I'm not sure if our first speaker is waiting in the virtual lobby or not. No, she's not. So we'll go to our second speaker this morning, and that is Dr. Dustin Sulak, a physician, author, educator, and healer from Cumberland County, Maine, in the US. Dustin is an integrative osteopathic physician and leader in the emerging field of cannabinoid medicine. His clinical practice focuses on treating refractory conditions in adults and children. He is the founder of Integrate Health, a medical practice in Maine, providing specialty cannabis and integrative care to thousands of patients, and Healer.com, a medical cannabis education resource. He is a passionate teacher of clinicians, patients, and industry professionals, and sits on the board of directors of the Society of Cannabis Clinicians. His presentation today is called A Year in Clinical Trials. Please welcome Dr. Dustin Sulak.
Hello, everyone. I hope you're having a great conference. I'm sad that I can't join you in person. I would love to, but my schedule didn't allow it. And I'm so thankful to the organizers of United in Compassion for putting on this great event and for inviting me to present remotely. My name is Dustin Sulak. I'm a physician that's been practicing with medical cannabis in Maine, United States for the last 13 years. And in the next half hour, I'm going to present to you what I consider to be some of the most exciting and relevant new human studies that have come out regarding cannabis in the last year. Let's pull up the slides and get started. We're going to cover 7 studies, so they're going to be fast. The first on cannabis, opioids, and benzodiazepines in patients with chronic orthopedic pain. Another one on the impact of medical cannabis use on neurocognitive function in adults. And then we're going to cover a few different studies on adolescent cannabis use, because this is becoming a lot more prevalent in my practice. And I think there's some important questions we need to ask about the safety and perhaps the efficacy of adolescents who choose to use cannabis. Low-dose cannabis study in patients with glioma that I found very interesting. CBD smoke in patients with psychosis. A couple studies on salivary biomarkers in patients with autism spectrum disorder. And then finally, we're going to look at data from a large group of medical cannabis using patients out of Israel. So hold on for the ride. Let's get started. To begin with, this is a study of 468 patients at a large orthopedic practice in Philadelphia, Pennsylvania. The average age was 61, 56% of them were female. Most of them had back pain or multifaceted pain. And they were assessed at baseline, and then 3 months, 6 months, and 12 months after starting to use cannabis, both in terms of their pain on a visual analog scale, and then several other measures of physical, mental health, quality of life, and so forth. This was funded by our National Institute of Drug Abuse. The researchers also looked at the Prescription Monitoring Program, which is a statewide database that looks at how many opioids or benzodiazepines or other controlled substances are being prescribed and dispensed to these patients. So let's start with how are they using cannabis? What are the use patterns like? Well, interestingly, a lot of them, you can see the number of patients here on the x-axis. A lot of patients were using once a day or 2 to 3 times a day, but some of these patients were only using cannabis 5 to 6 times a week or 3 to 4 times a week. I found that interesting. A lot of patients with chronic pain end up using it daily because the chronic pain is daily. So something a little different about this data that I wasn't expecting. And then if you look at, well, what type of product are they using during the day or at night? It's really all across the board. Now, smoking is underrepresented in this data set because at the time, the state of Pennsylvania did not allow smokable products to be sold at the dispensary. They did allow vaporizing. So you can see, in general, we could group the gray and the teal together and look at inhaled, oral, sublingual in pink, and then topical in white. And you can see patients were using all different types of products, mixing it up. And if we look at how much they were taking or what percentage of THC they were taking, those who inhaled cannabis, again, it was really all over the board. Some were using potent THC products like 71% or more. This would probably be a THC concentrate or distillate inhaled through a vape pen. Oh, and some were using very low concentrations of THC. These were probably CBD dominant inhaled products. When we look at the oral THC, you can see a lot of people are just using a tiny bit, 1 milligram or less, 1 to 3 milligrams. Again, these were probably CBD dominant products, while some people were using 25 or more milligrams of THC per day. So a wide distribution in terms of use patterns. And I think that this is appropriate. So many people are often looking at studies and saying, well, what's the best way to use cannabis to treat pain? Or what's the best way to use cannabis to treat this condition, this diagnosis? And the answer is always, with cannabis, we provide an individualized treatment approach. We treat the person, not the diagnosis. And usually a cannabis treatment plan can be woven into somebody's life in a way that really fits them, in a way that provides multiple areas of benefit like sleep, pain, mood, activity, with very little side effect. And sometimes that takes a little fine tuning. Now, how did the cannabis impact them? Well, if you look at people that rated cannabis improves my primary symptom, strongly agree or agree. There were a lot more people in the group that thought cannabis helped them with their primary symptom compared to those undecided or those who disagreed. So a lot of people thought cannabis was helping them. And then if we look at some of the side effects or potential side effects, I found this interesting. The most common experience in 41% of these 400 plus patients, the most common experience was the relief of pain in the absence of intoxication. This means they did a good job with the dosing and the delivery methods. They were able to get inside what I call that therapeutic window, where you have a certain dose that helps the symptoms and another dose that causes side effects, and people usually can get inside of that. 52% of these patients did not experience intoxication, but of the 48% that did experience intoxication, I thought this was really interesting. 84% found that it was enjoyable or perhaps even therapeutic, or that it did not interfere with their life. So if you look at all of the intoxicated patients, almost 150 of them, very few disliked the intoxication. Most thought it either wasn't anything worth complaining about, nothing big, or that it was actually enjoyable or beneficial. And this is something that I've been talking about for many years. For those of you that know my work, you know that I like to recognize that the psychoactive and the euphoric aspects of medical cannabis are some of the most important and most therapeutic in promoting a good quality of life, relieving symptoms, and helping people change their patterns of thought and behavior to be able to relate to themselves differently and to the world differently. It's really one of the special powers of cannabis. Now, what happened to their symptoms? Well, as you can see here, in the first 3 months, the visual analog score for pain decreased and it stayed down over 12 months. Quality of life increased significantly and it stayed increased over 12 months. Global physical health improved and remained improved, and global mental health improved and remained improved. This looks like pretty good results for people using cannabis to treat chronic orthopedic pain. But it doesn't end there. Let's take a look at what happened with the opioids. This is the morphine milligram equivalents, both the total taken over 6 months and the average daily dose. And you can see that both of these went down. If you look over on the right at the pie chart, you can see that 72.6% of the patients in the study either decreased or totally stopped using opioid drugs. So this is almost 100 patients stopped and another 100 decreased their dose, while 65 increased and 9 had no change. This is remarkable. Find a cohort of patients with chronic pain that are using opioids. I don't believe that there's any other treatment you can give people in that situation that would result in 72% decreasing or stopping their opioids. And this is not the first study that's reported this. There are now several, all in the same range. Now, looking at the opioid users a little more in depth, what you see here is that those that were on the highest dose of opioids, greater than 30 morphine equivalents per day, had the strongest reduction in their dosing. So it seems like the opioid sparing effect, at least in this cohort, was most pronounced in those that were on higher doses of opioids. And we didn't really see an opioid sparing effect in those that were on the low doses of opioids. And perhaps that's because those individuals found that the low dose of opioids plus the cannabis was an effective combination therapy. That's what I see a lot in my practice. Now, interestingly, these patients who didn't necessarily have anxiety or muscle spasms, even though I'm sure a lot of them did, this was a focus on orthopedic pain, but of course there's numerous comorbidities with pain, including anxiety, depression, spasticity, and other symptoms. Well, these patients also reduced their benzodiazepines, which are the skeletal muscle relaxants and anti-anxiety drugs that are highly addictive and also dangerous to use in combination with opioids. 69% of the patients in the study were able to decrease or stop using their benzodiazepines based on data from the prescription monitoring program. Really impressive. Limitations of the study is that patients were self-enrolled, so there could have been a selection bias for those who had better results with cannabis. There was an assumption that the opioids and benzodiazepines taken as directed, because this was PMP data, no one actually watched them putting these pills in their mouth. There were no placebo controls and no way to identify what cannabis regimen works best, because I don't think there is one that works best. But this was a nice study. The interesting findings is that the therapeutic benefits occurred with infrequent to moderate cannabis use. I didn't expect this. I thought the daily users would get better results than the intermittent users, but that didn't seem to be the case. And also a good take-home message is that the majority of patients were able to self-titrate, meaning adjust their dose in a manner that produced beneficial effects in the absence of intoxication. Let's move on to our next study. This is from Stacy Gruber's group out of Harvard. They looked at 54 medical cannabis patients over the course of 12 months. They were evaluated at 3, 6, and 12 months. 26 of them were cannabis naive, defined as having used it less than 15 times in their life. And 27 patients completed all 4 of the visits. They looked at the dosing that the patients were using, the analysis or certificate of analysis of the products, and multiple cognitive tests. And what they found was that over these 12 months, in the patients who were already cannabis users and in those that were cannabis naive, there was no evidence of worsening cognition during that treatment period. In fact, these patients improved on several executive tasks. This means that their brain, their neurocognitive function actually improved after 12 months of using cannabis. Their verbal learning and memory were stable, and they also showed improvements in mood, anxiety, and sleep relative to baseline. So what's the take home here? A lot of people think, oh, if I'm going to use cannabis, maybe it'll help me with my symptoms, but there's going to be a trade-off. I'm going to have to feel high or stoned or dull or dumb, or my memory is going to be bad, or my thinking is going to be slow, or something like that. This study and the previous one, which showed that people didn't mind the psychoactive effects, they disrupt that concept. And I really see this in my clinic, and I want to drive this message home that cannabis can be used without detrimental cognitive effects. Now, in this cohort, neither THC or CBD was directly correlated with improvements in executive function. Again, there's not a one recipe fit all kind of picture here, but if people are able to adjust their dose and figure out what works right for them, that's going to work the best. Go figure. Increased CBD exposure was associated with better mood and anxiety symptoms. And the strongest improvements in cognitive performance were also associated with the strongest improvements in clinical symptoms. So this paints a holistic picture. The people who cannabis works best for, it's helping with their physical symptoms, which in this case were mostly pain patients, but it's also helping with their brain function. It's probably helping with their sleep and anxiety, and it really helps people globally. Such an incredible medicine. Now let's shift gears to adolescent cannabis use. Why do I want to shift gears to that? Because over the last 2 years, more and more parents are bringing their adolescents into my office. Either the parents are figuring out that the kids are using cannabis and then they're taking it away and punishing them, and they see the grades go through the floor and the social life deteriorates, and then they give it back and they ask their pediatrician, what am I doing? I'm giving my, letting my kid do this illegally, and the pediatrician says, go see Dr. Sulak. So that's the most typical scenario. I see a lot of adolescents that are on antidepressant drugs and anti-anxiety drugs, and even stronger psychiatric medications like antipsychotics. Uh, these drugs aren't working that well and carry a high burden of side effects. And parents are also coming in interested in something that might be safer and more effective as a substitute for those medications. And at the end of this presentation, we'll look at drug substitution, which is a powerful feature of the therapeutic effects of cannabis. So let's start with this study, which is not, now this isn't necessarily looking at people that are using it medically. I'm sure some of these subjects are self-medicating for certain symptoms, but this is just cannabis use in general. And this is a review article. It looked at a longitudinal association between either frequent or dependent cannabis use and IQ change. And the criteria for the studies they looked at were people that started using cannabis before the age of 26, that had used it for at least weekly for 6 months. And then they also had a control group that had less than 5 lifetime uses of cannabis to compare these cannabis users to. So with that criteria, they found 7 studies that they included, 808 cases of cannabis use in young people, and over 5,000 controls from the UK, USA, Canada, and New Zealand. And most of those 7 studies controlled for alcohol use, which is obviously a major confounder. If somebody's using cannabis and drinking, it might look different in terms of their IQ than if they're just using cannabis alone. So what were the results? There were no baseline differences, first of all, in the control and the cannabis group. So they started off at the same place in terms of their overall IQ and their verbal IQ. And then looking longitudinally, like over time, as people started to use cannabis and started to use cannabis more frequently, putting all that data together, was there an association between cannabis use and a decrease in IQ? The answer was yes. And that decrease was a little less than 2 points. Now, specifically, if you look at a subset of IQ called verbal IQ, the decrease was almost 3 points. How big a deal is this? 2 points or 3 points? Well, what the authors stated was that this is not clinically significant, and that alone, it's unlikely to completely explain a range of psychosocial problems linked to cannabis use in this cohort. So what does this mean? Over time, people have studied young people that use cannabis, and they realize that they have all sorts of more problems than the young people who don't use cannabis or don't use other substances. They might have more anxiety or more depression or lower performance in a variety of areas. But I think what this study is pointing out is that because this is longitudinal data, it looks very unlikely like those problems are due to cannabis. They're probably using cannabis due to those problems in an attempt to help themselves. Now, how does this compare with alcohol use? Looking at an older study from 1994, it showed a 10-point decrease in IQ in adolescents that were diagnosed with alcohol abuse or dependence. So again, I think young people are very likely to use substances, to try things out, and this makes cannabis look a lot safer than alcohol. And again, I think it gives us a little reassurance. These people did not have medical supervision. They did not have clear goals of treatment. They were using cannabis on their own. Imagine what we could do to further reduce the potential harm with that type of supervision and support. Here's another study looking at the residual effects of cannabis use on neuropsychological functioning in adolescents. So new data from last year, 804 adolescents. Average age was 14 and a half at baseline, and then almost 19 years old at follow-up. So this is some very interesting longitudinal new data that wasn't included in that other study. And they performed neurocognitive tests. The subjects self-reported their substance use, and none of them were cannabis users at baseline. What did they find? Looking at the people who started using cannabis over those average of 5 years, there was no evidence of effects of cannabis on attention, working memory, short-term memory, and risk-taking. The author said this could be due to various reasons. First, we examined subclinical cannabis use as compared to most studies focusing on patients with substance use disorder or dependence. So these were the more normal using adolescents, using it maybe once a week or even once daily, but without a real problematic use pattern and no negative effects on their cognition. They said, in summary, We find no evidence to support the presumption that cannabis consumption leads to a decline in neurocognitive ability. If anything, our findings suggest that light cannabis use and late onset thereof do not disrupt normal brain development with regards to decision making. So that was the most they could say, that it didn't make their decision making worse. But when you actually look at the data, this is the decision making performance. In the light gray, we have it baseline, and in the dark gray, we have it follow up. Look, the decision making did improve in the non-cannabis using control group, but it improved even greater in the cannabis users. Yeah, it was lower at baseline, and then with cannabis use, their decision making improved in both the early onset cannabis users and the late onset cannabis users, and that was statistically significant. Very interesting data that might suggest that adolescents who use cannabis in a non-problematic way may actually get some benefits from it. And again, these individuals were not under medical supervision and did not have clear goals of therapy. Here's another one: evidence lacking for cannabis users slacking, a longitudinal analysis of escalating cannabis use and motivation among adolescents. It was a systematic review of the associations between sorry, this was not a systematic review. This is just a little background information. So basically, a previous review from 2018 looked at adult data on cannabis use and motivation and found that it didn't really show anything. Does cannabis make it better or make it worse? No real answer there. And again, we're specifically talking about motivation. There have been 2 adult longitudinal studies that did support the hypothesis that heavy cannabis users are less motivated and have less reward sensitivity, which means they're going to be less motivated to do things that provide natural reward, like success. So in this study, there were 401 adolescents from Miami, age 14 to 17 at baseline. They included 90% of these adolescents were using either alcohol, cigarettes, or cannabis. They were disqualified if it was a substance use disorder or heavy use. So again, this is looking at the more normal range of use, not the super problematic use. And they were given scales about apathy, motivation, engagement, depression, anxiety, and stress 5 times at 6-month intervals over 2 years. What did they find? Well, first of all, at baseline, those who were already using cannabis when they started this study, they had the more frequent cannabis use was associated with lower valuing of school. That was the only thing. Like, so at baseline, if you were a heavier cannabis user, you were less likely to value school. I find that interesting. And females who reported higher levels of self-efficacy at baseline also reported greater escalation in cannabis use over time. So what does this mean? The young women who scored higher on self-efficacy, which means they can basically take care of themselves and keep their life organized and have better self-governance, they were more likely to increase their cannabis use than the rest. Now, looking over those 2 years, cannabis use frequency did increase significantly. The 2 facets of motivation, called disengagement and planning, also increased significantly over time. Other aspects of motivation remained stable. And after controlling for covariates like those other substances, there was no link between cannabis use and reduced motivation. This study did not show in any way that adolescents who start using cannabis or who increase their frequency of cannabis use over 2 years have any negative effects on their motivation. That's interesting. And a quick comment on that, what I suspect it can do is alter their motivation. And I think that little tidbit about lower valuing of school, I mean, of course, any curriculum that's going to be applied to a large number of students is going to be too fast for some and too slow for some, and there's going to be boring parts for some, kind of like cannabis treatment. One size doesn't fit all with education, even though we try to make it that way. What I suspect cannabis does, and what I see in my patients, especially my adolescent patients, is it might in fact make them less motivated to fill their days with activities that are non-congruent with their highest values, but it makes them more motivated to fill their days with activities that are congruent with their highest values, which of course is beneficial for mental health and for their long-term success. So I don't call it amotivation syndrome, I call it altered motivation syndrome. And I suspect that when cannabis is used appropriately, it can have a remediating effect on motivation. All right, we're going to switch gears big time here from adolescence, but I wanted to review all of that because what can I say? I'm just going to back up for one more second here. It's a very hard time in the world right now to be an adolescent. There are so many stressors that we did not grow up with and that we are not used to, from social media to all this COVID lockdown business to the cognitive dissonance. They're watching adults, they're watching their leaders in government, they're watching their authority figures behave in a way that does not make sense to them, that does not follow logic, that is biased and bizarre. It's so stressful to be a teenager right now. Their thoughts and behavior are so heavily influenced by the technology that they're plugged into. It's an important population for us to take care of. And I do believe that cannabis is a safe and effective solution when used under medical supervision to help a lot of these patients. Shift gears here to patients with glioma. Those of you that know my work know that I've always been very interested in the very low dose range of cannabis. And so this study really speaks to that. So this was a single center phase 2 double-blind randomized controlled trial that looked at 2 different types of oral cannabis oils in patients with recurrent or inoperable high-grade gliomas. These are brain tumors. And this was funded by Fit Biopharmaceuticals in Sydney, Australia. It was a 12-week study. There were 64 patients, and then they also had 61 other patients that didn't use cannabis to serve as a control. Average age was 53, and 29% of the 92 original patients died before or during the trial. I point that out because anytime you have a 30% dropout rate due to death or anything else in a clinical study, it detracts from the quality of the conclusion statistically, from the data. But I still think that this is very interesting. They looked at the side effects, the quality of life, and what happened on the MRI. Did the cancer grow or shrink or do nothing? So what were they taking? Very low potency cannabis medications. One was a 1-to-1 ratio of THC and CBD in an oil, roughly 4.5 or 5 milligrams per milliliter, so not very potent stuff. Another was THC dominant, so 15 milligrams of THC and 4-ish milligrams of CBD per milliliter, a little stronger, provided by Whistler Medical Marijuana Corporation. They took this just once a day at night, starting with 0.2 milliliters, which is a tiny, tiny dose, and then working up from that every 2 days with the help of a telemedicine visit with a nurse. So what did they find? First of all, what did they end up taking after they titrated to kind of their ideal dose over those 12 weeks? Those that were using the 1-to-1 formula were taking about 10 milligrams of each, THC and CBD. And those using the 4-to-1 ratio were taking a much higher dose, 27 of THC and 6 of CBD. So this is an ultra low dose, but it's interesting that it's just a nightly dose, just taking it not all day long every day, but just once before bed. What were the side effects? Dry mouth was the most common at 13%. Tiredness, which is probably a good thing for a lot of people, not necessarily a side effect. Dizziness and drowsiness. At week 8, 4 of the subjects reported mild hallucinations, some paranoia or euphoria. And of course, that's due to this high dose of THC. But what do we see here? So in the cannabis group, 11% had a reduction in tumor size, 34% had stable disease, and 27% had progressive disease, meaning the tumor grew. Looking at that control data of the non-cannabis users, none of them had a reduction in tumor size, 45% were stable, and 53% had progression. So you see, compared to controls, cannabis seems like it was having an anti-cancer effect here, which is very interesting. Also, looking at dexamethasone administration, this is an anti-inflammatory steroid that's often given when people have inflammation in the brain, which can be a result of the cancer itself or the cancer treatment like chemotherapy or radiation. A lot less dexamethasone was used in the cannabis group, perhaps because the cannabis was providing an anti-inflammatory effect in the brain, which it probably was. And then looking at this bar graph here, looking at the difference between the 1-to-1 and the 4-to-1 ratio and their response, basically what this shows is there wasn't much of a difference. It's not like the people that were using the higher doses of THC did any better. They were pretty much the same: partial reduction, stable disease, mild enhancement, and so forth. So I think this is a very interesting study, because a lot of people that think about how can I use cannabis either as a monotherapy or more often as an adjunct to conventional cancer treatment, how can I use this to help fight the cancer, to help me recover from cancer? And most people think that they need these heroic doses of cannabis, hundreds of milligrams per day. And I'm sure that in some people that is the best way to go. But I'm very interested in data that shows, wow, this is kind of like a normal dose that someone might use just to help them with sleep, also having what looks like an anti-cancer effect. Really impressive. Their physical and functional domains were statistically significant in favor of the 1-to-1 ratio. So maybe because of less side effects, but people seem to do even better on that 1-to-1 with the less THC. Sleep improved in both groups. Well-being improved in both groups. So this wasn't just helping with their cancer. It wasn't just sparing dexamethasone. It was helping them function, helping them feel better, and have a better quality of life. The conclusion was a single nightly dose of THC containing cannabis was well tolerated in patients in both groups with high-grade gliomas, and significantly improved sleep, functional well-being, and contentment with quality of life in a sample of patients compared to baseline. All right, this is a quick one. Another little study: CBD cigarettes as an adjunctive treatment for psychotic disorders. This study looked at 48 patients with acute psychosis that were both cannabis users and tobacco users, and they were given tobacco cigarettes that were actually just 80% tobacco and 20% CBD containing hemp, on average 20 milligrams of CBD per cigarette. They were randomized to those who received just regular cigarettes and these hemp infused cigarettes, except it was open label because everybody could tell which ones had the hemp. So they had originally wanted to make it double blind, but they couldn't do that because of the odor. And they were followed for 25 weeks. And what they found was that there was higher ratings of well-being and less antipsychotic medication use in the CBD group, and no difference in the amount of cigarettes or cannabis that they consumed. Looking here, this is a graph of a measure called PANSS, P-A-N-S-S, which looks at their psychotic scores. Not a big difference. You can see that the CBD group, scored a little bit lower on average, but that was not statistically significant. So overall, the symptoms were similar in these two groups, but what was interesting is that the antipsychotic medication dosage stayed at the same level in the CBD group. And you can see that it went up on average in the non-CBD group. So there was an antipsychotic sparing effect. Now, we know from previous studies that very high oral doses of CBD, unaffordable to most people, can have an antipsychotic effect. But I think this one's really interesting because you can get higher blood levels using the lungs as a route of administration. And that's what these researchers were looking at. And it seemed to have an effect. So I would love to see this again with even higher doses, not just 20%, but maybe 50 or 80% CBD in those cigarettes, or just give them pure hemp cigarettes. That might work even better. Okay, let's move on. I know we got to wrap up, almost done here. These are two studies published by a group that includes my friends and colleagues, Donald Abrams and Bonnie Goldstein. This is really interesting, cutting edge work here, looking at 15 patients with autism spectrum disorder and 9 neurotypical controls. What they did was they measured their saliva for a huge range of biomarkers that might be related to their condition of autism. They took the saliva at baseline, they administered the cannabis to these patients, and then they checked the saliva when the cannabis seemed to be working. Now, these patients were all treated with a unique individualized dose by Bonnie Goldstein. So you can see here, like, it's all over the place. No cookie cutter treatment regimen here. Some were using edibles, which means something was added to their food, not like a store-bought edible, and others were using tincture. But you can see some were using THC in fairly high doses, like 50 milligrams. Some were using per treatment. Some were using no THC at all. Some were using CBG in fairly high doses, some CBDA. These two categories, THCA and CBDA, I'm very interested in. But basically, Bonnie had adjusted their dosing as best as she could to get them dialed into an individualized approach. Now, I'm not going to go into details here, but what you're seeing in these charts are three classes of biomarkers. And one is the sphingolipid class, the phospholipid class, and the fatty acid class. And these orange bars here. Okay, so on the y-axis, we have A1 through A18. These are the different patients. And then these orange bars, the negative 2.0 and 2.0, these are the standard deviations based on the data from the controls, from the people that were neurotypical. They did not have autism. And so you can see before receiving cannabis, most of these individuals had some biomarkers that were far outside the range. Now look what happened in the saliva after they received their normal dose of cannabis. I think that this is just incredible that you can real time measure the normalization of these biomarkers, which are indicative of what's going on in the brain, especially in relation to inflammation, but also brain function. So this is real world, real time proof that cannabis is helping these patients. I know I'm going over. Give me just a couple more minutes. This last one is worth ending on. This was a prospective study out of Israel looking at thousands of patients. Altogether, they had over 4,000 patient data endpoints in terms of efficacy, and even more than that in terms of adherence to treatment. 54 was the average age, about half male, 30% had prior experience with cannabis, the other 70% did not. These were the symptoms that they were presented with before using cannabis. It was sleep disturbance was the most common, pain, weakness, and fatigue. But look down this list. I mean, you can see everything, under the sun, all sorts of different conditions. In the end, the symptoms that had the highest level of improvement, rage attacks scored number one, restlessness came in second, sleep disturbance close third, and nausea. Oh, I think yeah, and nausea just under that. But these were all up in the 90% range. Now, as far as treatment success, you can see here cancer, nonspecific pain, PTSD, autism, epilepsy. We're above 50% in all of these different conditions. What other single medicine do you know can provide greater than 50% success in almost every condition studied across the range of disciplines of medicine, psychiatry, neurology, gastroenterology, pain medicine, and so forth. It's really impressive that in this huge population, we see these kind of results. Let's look specifically at pain. In the orange bars, you see the pain levels before treatment. And you can see a lot of people had pain at a level 8, 9, and 10 before using cannabis. 6 months later, almost none of them had level 8, 9, or 10. The whole thing was shifted in the blue bars over to a lower pain intensity. And then if you look at quality of life, again, these are thousands of patients who have improved their quality of life. Before treatment in orange, almost none of them said their quality of life was good or very good. After treatment, most of them said their quality of life was good or very good. If this is what we can do for patients with medical cannabis, I think it's incredible. And I know for a fact that this is the truth. I see it in my clinic, and I'm sure many of you see this as well. Real quickly, I just want to end on drug substitution. So how many people decreased or stopped their opioids in this cohort? 38% of those using opioids stopped completely, 13% decreased their dose. How about antidepressants? 25% stopped completely, 6% decreased. 25% of those on anti-epileptic stopped, 16% of those on peptic ulcer or GERD drugs stopped, antithrombotic agents, anti-anxiety agents, anti-cholesterol agents, sleeping aids, other types of pain relievers, ACE inhibitors for blood pressure, diabetic medications outside of insulin, more hypertensive blood pressure medications, steroids for inflammation. I mean, every class of medication. So you have an herb that can treat, I'm going to stop the slideshow now. You have an herb that can treat almost every discipline of medicine's toughest conditions, that can substitute almost every class of medication. It's just incredible, and we see how safe it is. Thank you for your time. I'm sorry that I ran over, and I hope to be with you in person in the future.